Yes, so we are live on YouTube. I'll just do countdown as usual and then would request Dr. Mallikarjun to give background of IACP, our webinars, and then start the proceedings. So 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Welcome to IACP Webinar 3. I request the President of IACP, Dr. Mallikarjun, to start the proceedings, please. Dr. Mallikarjun, you'll have to unmute yourself. Dr. Lahane, we welcome you to IACP Webinar 3. Dr. Lahane has joined with all of us.
I'm sorry. Good evening on behalf of Indian Academy of Cerebral Palsy. We welcome all of you to the IACP webinar. This webinar is third webinar in the series organized by IACP in association with Bombay Ophthalmologists Association and CRC Guwahati Ministry of Social Justice and Government of India. It is my privilege and we feel honored to welcome legends in the field of ophthalmology to this webinar. Dr. Padmasri, Dr. Lahane, we thank him for accepting our invitation within short notice to inaugurate and bless this webinar. IACP is honored to welcome world-renowned and highly respected ophthalmologist, divine teacher, Dr. Gordon Dutan, to our webinar 3. We are very honored, sir. Thank you, Usha Madam, for getting him to this webinar. And we welcome our dearest Dr. Usha Johari Madam, who is our architect of this webinar. Without your vision, this webinar would not have taken, Madam. And she is actively working for the vision for cerebral palsy children, and we are planning to have a wonderful project we are going to take up under her leadership next year. Thank you very much, Madam, for getting all the cream and reputed divine teachers to the webinar, and IACP is honored with your kind act. And our sincere thanks to the Dr. Siddharth Kesavani and Dr. Krutisha for accepting our invitation. And it is our pleasure to welcome a surprise guest, Dr. Banaji, past president of BOA, and Dr. Firoz Patel, past president of BOA, and all our team members and board of directors and EB members. We welcome to the webinar and hope that today is going to have a wonderful feast on Vision 2020 in cerebral palsy. And our Shashikala Madam also informed us that we are planning to may share Dr. Dutton's poem on CVI. And thank you very much. And I request our secretary, Dr. Sektidas sir, to introduce Dr. Lahane.
Good evening, respected President, Board of Directors, all the Board of Directors and Executive Body members. This is an opportunity to introduce such a great man amongst us, Padmasri Professor T.P. Lahane. At the outset, I convey my sincere thanks to him because during this busy time, he has availed himself for all of us during this time, for some time. Sir, welcome you, sir. Let me, because problem in Maharashtra and Pune, he is so busy. And let me introduce him. Professor Tatiyarao Lahane is born at one of the remote place in Latur district of Maharashtra. Currently, he is the Director of Medical Education and Research, Mumbai. He is a renowned ophthalmologist par excellence. And most important is, he has served the whole of the state of Maharashtra and other parts of the country, doing so many camps, helping poor patients by mainly cataract surgery. He has almost reached all the places of Maharashtra, and he has dedicated life to the affordable care and treatment of the eye problems in the Maharashtra, rural and tribal areas. He has visited. Most important is the excellent surgeon. He has operated more than 2 lakhs eye surgeries, and he was the dean of JJ Medical College. During his time, he has developed the OPD complex as well as almost modernized the whole of the Department of Ophthalmology in JJ Hospital. So, and most important is he has been conferred with the one of the 4th highest award of the country is Padma Shri in year 2008. Sir, I on behalf of the Indian Academy of Cerebral Palsy welcome you to this webinar for your guidance. Thank you very much, sir.
Thank you very much, Dr. Shaktidas and Dr. Mallikarjun sir. Thank you very much. Thank you, Usha. I came here because the Usha was behind me, and I really this Indian Academy of the Cerebral Palsy are doing an excellent work, and I'm very happy to know that. And this is the 3rd webinar, so I think I was part to inaugurate, and I will definitely say that the session of this is open. I have a few slides. I will just go through this, and then after that I will now this you will have to allow me to use this screen sharing so that I can present few slides.
So please share your screen, sir. Please share your screen.
Okay. Now this is what I want to tell you.
So there will be a green button called share screen. Just press that.
It is. Can you see now or not? Can you see now?
Yeah.
Yes. Can you see this or you can't see this? Slides, can you see now or otherwise no?
No.
Then I will do. Okay. No problem.
Share screen, sir.
That I will have to go to the share screen. Yeah. I don't know what has happened now. The host has spotlighted your video. Something it is saying that host.
So you can try now. Please try. Yeah. Share your screen.
Okay, 1 minute. Okay. Now I can write share.
Yes, sir. It's come. It's come.
Wow. Good.
Yes.
Now I can do it. Okay.
Yeah. So you have to go to PowerPoint.
I will have to go to PowerPoint now. Where has it has gone now? My PowerPoint is closed down.
So what I will just guide you. So unshare your screen, start your PowerPoint, and then reshare your screens.
Okay, now I will have to unshare it. Okay.
Unshare it. Stop sharing first. There'll be a red button called stop sharing.
But that now I think because I will have to go somewhere. Okay, I will see. Stop video.
So otherwise,
I can. What can I do now?
Yeah. So you go on top. There is a cross button. Next to that, there is a minimize button. So just press that. Yeah. Okay. Yes, sir. Please press that.
Now I can
start your PowerPoint, please.
Okay.
Yes, sir.
can.
Oh, sir, please email.
1 minute.
Your
Okay, now my PowerPoint is there.
yes, sir.
Okay, it is coming. Can you see now this?
Yes, sir, very well. It's opening. We can see that it's opening.
Okay.
Now make it full screen, please, sir.
Thank you. Thank you very much. Huh?
No problem,
So
sir.
I will make it full screen. Okay.
Yeah, yes,
Okay.
absolutely. We can see it very well. Please start your talk, sir.
Sorry, sorry, I took some time. Now, this is the epidemiology. If you see the Indian, 3 out of 1,000 live births, you get the cerebral palsy. And this is 2013, this one, census, 25 lakhs CP children are there in India. And more than 60,000 births per day. And more than 68 lakhs children with disability are there in India. You see what I want to tell you. You can see you can't see this such type of thing is there, so you can't locate, and because we see all other things trees, so like that the vision in cerebral palsy is not seen properly. So here also you can see the all, but it is not seen by the people. They see the other disabilities in the CP, but they forget the vision. So now this is, you can see the ocular finding in patient with the so many spastic types and cerebral palsies are there. And here more than 50% patients are having the refractive error. 50 to 70% patients are strabismus. And then you see the treatable if diagnosed early. So what happens, we never diagnose it early. Then what? Then what happens if not diagnosed and treated? So it is a sequelae of the delayed visual rehabilitation. You see the person is blind. Then you get the amblyopia, low vision, glaucoma, optic atrophy. Added visual disability to the previous physically handicapped child. This is just because it was not seen. Then see, why do patients delay in the visiting eye hospital? Because the importance of physical disability is more than the visual. Lack of guidance, the skeptical about the glasses, assumption of the normal eyes. They feel that eyes are normal and vision is normal, and fear of disease diagnosis. And because of that, the patients are not shown to the ophthalmologist. Now, how we can help it? See, pediatrician, orthopedician, physiotherapist should refer patient to ophthalmology. Patient should be concealed refractive error, cataract, or treatable diseases. Local social awareness program, national, international guidelines inclusive of ophthalmologist role in the management of CP. As we are doing in the RP, it should be in CP also. And in summary, ophthalmic evaluation is important not only in CP, but all physical disorder children. CP needs multi-specialty approach. Visual rehabilitation and glasses to the child is not an addition of disability, but correction of disability. And let us make their life as a better as possible. That is what is the message I want to give on this. And thank you very much. So I will now, how to come out now?
Yes, sir. You can stop sharing. So you stop the PowerPoint. Go to the cross button on the right, sir.
Okay.
Okay. Okay. Then again, put cross.
Okay, stop sharing. Okay.
Stop sharing. Absolutely. Thank you very much, sir. Thank you very much.
Thank you. So thank you very much. I am joining this conference, and really thank you, and I appreciate your work. Thank you very much.
Lane sir,
Thank you very much, sir.
Thank you, sir.
thank you, Lane sir. Thank
Thank you,
you.
Usha. Thank
Thank
you.
you.
Thank you, everybody. Thank you. Thank you.
Dr. Mallikarjun will now introduce our moderator. I request Dr. to introduce our moderator.
It is my pleasure to invite Dr. Siddhartha Kesavani, who is a leading ophthalmologist in Mumbai. He is a leading ophthalmologist, pediatric and neuro-ophthalmologist, and is presently working a consultant in a JNR Eye Clinic, Mumbai, ex-consultant LV Prasad Eye Hospital Institute, Bhubaneswar, and is an assistant editor, Indian Journal of Ophthalmology. And his areas of interest: research methodology, complex strabismus, and neuro-ophthalmology. And is a good teacher, and Madam got him to this webinar. We thank for his accepting our invitation to moderate this webinar. Thank you very much, sir. We welcome our hearty welcome to this webinar, and Dr. Siddhartha Kesavani to request him to moderate the webinar 3.
Thank you very much, sir. Thank you very much for inviting me and giving me this opportunity to moderate this session, which has such stellar gathering of presenters. Hello, everyone. Great to see so many participants from all across the country. Let me brief you about the program today. Our first speaker will be Dr. Usha Johri, who will speak to us about the incidence of common eye problems in CP. She'll be followed by Dr. Niranjan Pere, who will talk on what ophthalmologists know about CP and vision. Then Dr. Gordon Dutton will enlighten us on identifying visual difficulties in children with CVI. And in the end, Dr. Namita Jacob will brief us about rehabilitation of such children. We will have questions and answers in the end. So kindly type your queries in the chat box if you are on Zoom, and in the comment section if you are on YouTube. Let me now introduce the first speaker, Dr. Usha Johri. Dr. Usha Johri is a senior consulting ophthalmic surgeon practicing in Mumbai. She has been president of BOA in the past and is executive committee member of several organizations. The cause of children with cerebral palsy and multiple disabilities is very close to her heart. She is very passionate about this subject. She will be talking to us about common eye problems in children with cerebral palsy. Dr. Usha Johri, the screen is all yours. So you can share your screen and start.
Yeah. Thank you very much. Okay. Can you hear me? Yeah.
Yes, ma'am, we can hear you.
Yeah. Okay. A very good evening to all of you, and thank you IACP for organizing such a wonderful webinar and making me a part of this webinar. So let me start saying that what we see in fact is made in the brain from signals given to it by the eyes. So what cerebral palsy means to ophthalmologists is something which is still a niche. And so I would describe cerebral palsy. Yeah. I would describe cerebral palsy as a disorder of movement and posture resulting from permanent non-progressive defect or lesions of immature brain. So this we see in the form of monoplegia, diplegia, hemiplegia, or quadriplegia, and this is related to the description of the limb and the limbs only. Now, the classification of cerebral palsy for the physiotherapist and for the pediatricians, I think it's very well known. But from the ophthalmologist point of view, I've classified, the classification is very simple. The spastic variety, which involves, pyramidal tract, and 60% of these lesions dominate in the cerebral palsy, which is where the muscle is involved. And the second type is the dyskinetic type, which is comprises of 35%, which is extrapyramidal in nature, where the posture is involved. And the third type is the rare type, the ataxic type, which is a cerebellar type, where it involves the balance system. Now, the incidence of cerebral palsy, as Dr. Lahane previously mentioned, is nobody is very sure about the incidence. But what I have gathered from the statistics is the occurrence is 1 to 2 per 1,000 population because of different etiology. The commonest cause is the perinatal brain damage. Now, the incidence of premature birth is increasing. We have excellent neonatologists who are taking very good care of these children. And that's exactly the reason the incidence of cerebral palsy is increasing. The latest statistics say that there is 1 in 278 children having cerebral palsy. Now, from the ophthalmologist's point of view, why cerebral palsy is important? Of course, we all understand that the poet says that the eye is a window to the soul. But as an ophthalmologist, I would say that the eye is a portal to the brain, window, and the tail of the brain. It's surprising to know that the 60% of the human brain has visual activity, and Nakoyama, way back in 2012, also mentioned that 40% of the brain helps in supporting and processing vision. So another surprise is that human eye has almost 2 million working parts. Now, the ophthalmic peculiarity in cerebral palsy is nothing new to us. It's been known over a century. But why has this visual disability been there in these children? Because of ignorance, it's been overlooked. There's a lot of social stigma, lack of education, and lack of economics in our scenario. And most of the parents always feel that the child should be, the extremity should be first taken care of, and eye comes to them at the end. If the general pediatricians recognize cerebral palsy around the age of 80 months, we as ophthalmologists know very well that the eye fixation takes place at 3 months, binocular single vision fusion and stereopsis takes place at 7 years of age. Then why is this late detection? The visual difficulties, normally the child that has in cerebral palsy is, from the parents' point of view, is sometimes the parents wonder whether the child can see, number one, number two, whether the child can react to the light, or does the child, after reacting to the light, has a fixed visual attention, and does the child react to the noises which are not visual, and of course the fixation and the head posture, and does the child pursue with the moving objects. And you'll all agree with me that mother is the first eye doctor for a cerebral palsy child. Now, attention to the parents. Mother being the first target, it's the child sees the mother's face. The parents normally complain that the child may blink excessively or may not blink at all and keeps gazing at the light and always prefers a bright color, which is a moving object, and turns the head away from the object. So indirectly, the child is using the peripheral vision. And most of the relatives, friends, where the child is moving, they all feel that, is this child a slow child? Now, the visual difficulties from the cerebral palsy from the child's point of view is the child does not have any problem at all, because the child feels the child is seeing what the other children are seeing, and the child is very happy in his or her own world. And this realization comes very late, and the other problem the child has is the child has difficulty in remembering things that they have seen. And of course, as they grow, they have tired vision and reading difficulty. Now, as an ophthalmologist, what we face is a fall in the visual acuity, fall in the sharpness of vision, field loss. Child has difficulty in focusing near objects, recognizing objects, keeping the fixation still on an object, and they have difficulty in using vision to move parts of their body around. Now, the incidence of cerebral palsy in visual loss in cerebral palsy is both brain-related, eye-related. Could be either of them. And in our study where we carried out, we found that 91% of the children had eye problems compared to Peter Black, who had only 80% of the children having eye problems. Another interesting thing that was noticed was that a child with cerebral palsy has multiple eye problems. It's not just one problem. So how can this be incidental? And can we make a difference to the lives of many children and families and maximize their visual potential? And of course, we can do it. So basically, we all know that the visual system in an infant and children is dynamic and very sensitive. So for better understanding, I have classified the problems into reversible, partially reversible, and irreversible, where reversible and partially reversible need a regular checkup and early detection because they're almost 100% correctable. Whereas the irreversible, we take the help of the visual rehabilitation specialist. Now, the reversible ones are commonest ones are the squint, refractive error, and cataract. And we need to give a special attention to accommodative disorders and anisoconia. And as the child grows, the refractive error keeps changing. So not to forget the annual checkup. And early detection is, of course, mandatory. Now, you'll all agree with me that a normal child who is a hyperope, as the child grows, reduces, whereas in a child with cerebral palsy, it's retained. Astigmatism also is retained in a child with cerebral palsy. Accommodative disorders, which are very important, which normally occurs in the middle age, appears very early in childhood. And myopia and anisometropia, of course, increases with age, both in a normal child and in a child with cerebral palsy. So the high prevalence of refractive error is very common in child with cerebral palsy. Now, what we mean by accommodation disorder is the difficulty in focusing the near objects. So the child, this accommodation occurs not only just because of the eyes, but it is within and beyond the eye because there is a reflex, or it's an automatic reflex which is complex right from the brain to the eye. Now, the spectacle therapy, imagine a child having impaired mobility, impaired communication, and over and above that, an impaired vision. So we do have special glasses for children, which could be progressive, bifocal, short curved sidearms with the shatterproof glasses. And a spectacle therapy is extremely important because we know that if we treat this child at an early age, the child can have the best visual outcome. And of course, the child is the best judge. The child, of course, realizes the difference when they see the objects around them. Now, the eye movement disorders in children with cerebral palsy is proportionate to the degree of cortical visual impairment. In general population, the squint is normally 3%, whereas in a child with cerebral palsy, it is 46%. Why this difference? Because in cerebral palsy, the squint is not only because of refractive error or the muscle imbalance, but it could be because of the lesions in the subcortical, oculomotor, and the cerebellar area. These are the few children who have got the divergent squint and convergent squint, and they've been treated. And a word of usage of Botox in certain cases. And amongst the ophthalmologists, we have 4 popular O's: the optical treatment, occlusion, orthoptic, and the operation. Now, developmental cataract, the causes could be maternal infection or malnutrition, which is a non-progressive white opacity in the pupillary area. And of course, the treatment for this condition is surgery. Now, coming to the partially reversible or partially treatable cases, which is amblyopia, retinopathy of prematurity, and the postural abnormalities of the trunk and the neck. Amblyopia, we all know in this condition, we always say that prevention is better than cure because there is a partial loss of sight either in one eye or both eyes, and there are absolutely no objective signs and no ophthalmoscopic findings. So this is how we treat amblyopia. And aggressive treatment, normally less than 7 years of age, because that's the period which is the end of the sensitive time. Retinopathy of prematurity, which is very common in low birth weight children. Most of the time, no treatment is required, but 10% of the children who go blind, it has to be detected early. It has to be detected at a very early stage. And there are 5 stages: mild, moderate, and severe, where the vessels are mildly abnormal, moderately abnormal, and severely abnormal. And in the stage 4, where we see a partially detached retina, and stage 5, which is the last stage, which gives rise to a complete retinal detachment. Now, the eye and the posture abnormalities in cerebral palsy, for example, torticollis, it is because of the retrochiasmatic damage of the visual system, which I have shown it with an arrow. And these children also have to be treated accordingly with either with an orthopedic surgeon who treats the thoracic abnormality and the torticollis, and we as ophthalmologists treat the eye problems. Now, the non-treatable or the irreversible causes are nystagmus, optic atrophy, birth defects, fixation loss, and the most important, cortical visual impairment. And we have with us the father of cortical visual impairment, Dr. Dutton, who will be talking on cortical visual impairment. So the next thing is the nystagmus, where we see that there is a periventricular damage, which could be either pendular, where the movement is in harmony, and it could be a jerky, where there is movement quick in one direction and slow in the other direction. We all know that the optic nerve is the tail of the brain, and see how healthy the normal optic disc looks compared to a case with an optic atrophy, which is a pale white disc. An optic nerve carries almost 1 million nerves from retina to the occipital row. Now, these are the few birth defects in the eye. There's no or eyes, which is called as anophthalmos, the coloboma of the eye, which is the iris, which is a pear-shaped iris, microphthalmos, you can see that one eye is smaller than the other. Then the disease of the retina, which is called as a retinitis pigmentosa, where you can see the bony-like corpuscles at the periphery, and the normal field and the tubular field, which is very common in retinitis pigmentosa. Now, cortical visual impairment, just if it is a lesion between the lateral geniculate body and the visual cortex, there is a fall of vision and the ocular findings are normal. And of course, when there is such a gross cortical visual impairment in this child, spectacle therapy would be inappropriate. And we see a slide of periventricular mucomalacia, which helps us in rehabilitation and diagnosis depending on the area of periventricular malacia. So there is a breakdown in communication between the eyes and the brain. Now, the visual brain, which has the dorsal system and the ventral system, the dorsal system helps us to move in space. And when there's a damage to this system, the child has a difficulty in getting down the stairs, walking sidewards, forwards, and even to grab a drink. Whereas a damage to the ventral system, the child has difficulty to recognize space and the objects and the places. Now, the saccades, normally in a normal person, there's a quick change in the direction and the eye can follow accurately on a fast moving objects, which does not happen in a child with cortical visual impairment. Now, the questions to be answered is, can cerebral palsy be detected in pregnancy, and is cerebral palsy hereditary? So it is not that, we alone can do anything. It is the ophthalmologist with all this, consultants, physicians, all the specialties which are mentioned here. We all have to work together to see that this child can be independent, and the important role is of the parents and teachers and the caretakers. Now, in my opinion, cerebral palsy still remains a mysterious entity. It's of course a very difficult, uncertain, with a lot of associated problems. And as I previously mentioned, there is impaired mobility, impaired communication, learning difficulties, and above all, impaired vision. So I would conclude saying that let's not say nothing can be done. Let's suspect, detect at an early age, and correct. And this is what, in my opinion, is the role of the eye surgeons in cerebral palsy. Thank you very much.
Thank you, Dr. Usha. Indeed a mysterious disease, and I hope that today's seminar clears some mysteries out of this disease. We'll move on to the next speaker. Can I have a slide, please? Our next speaker is Dr. Niranjan Fere. He's a very dear friend to me, and he has established his reputation as an expert in the field of cerebral vision impairment over the past few years. He has been an alumnus of the prestigious LVP Prasad Eye Institute at Hyderabad and was a consultant at the same institute between 2011 to 2019. He is presently working in Liberia in West Africa. He has received training at the Great Ormond Street Eye Hospital and also was closely mentored by Dr. Gordon Dutton in the field of cerebral vision impairment. He will be speaking to us regarding what ophthalmologists know about cerebral palsy and vision in relation to cerebral palsy. Over to you, Niranjan.
Thank you so much, Siddharth, for that kind introduction.
I request Dr. Niranjan to speak little loudly so that everyone can hear.
Sure. Can you see the slides now?
Yes, yes.
And am I audible clearly to all?
Yes, Niranjan, you can proceed.
Okay. So in view of poor internet connection here, I would like to put my video off. So good evening, everyone. At the outset, I would like to thank Team IACP and Dr. Usha Johari for organizing this important webinar and giving me an opportunity to be a part of it. The topic given to me is what an ophthalmologist should know about CP and CVI. Objectives of this presentation are to share some ideas about how to manage a child with CP in an eye clinic and how to manage low functioning type of CVI in CP. Now, when we say that a child has CVI, it just means that the visual impairment is due to some problem with brain. Something like saying that a child can't see due to a lens problem. It does not convey what exactly is the problem with vision. So we need to characterize these visual impairments in more detail. Under this umbrella term of CVI, we have several impairments like reduced visual acuity, visual field impairment, visual agnosias, difficulties with visuospatial orientation, difficulties with motion perception, oculomotor issues, so many issues. And it is a spectrum. At one end, we have a child who cannot even look at light, called as low functioning CVI. And at the other extreme, we have a child who can see things well, but cannot process and use that information very well. We call it as high functioning CVI. Between these two extremes, we can have visual impairments of different combinations. It is important to note that a child with low functioning CVI can also have vision processing related issues. So these are two ends of the spectrum. They are not mutually exclusive. In a typical developing country scenario like India, we predominantly see young children with very low functioning CVI with additional impairments in several areas of development. And while dealing with the children as ophthalmologists, we face two major difficulties. Number one is limited time. We need to take care of loads of children with several other eye problems. And more importantly, most of us do not have adequate training about handling such children. As doctors, our training is mostly focused on treating people with medicines or surgery. And rehabilitation is not given its due importance. So we always tend to think that it is someone else's job. Now let's quickly revise basics of visual processing in brain. After the visual information reaches occipital lobes, it gets processed there for visual acuity, visual field, color, and contrast. From there, the information flows in two directions. One is via ventral stream. It goes towards inferior temporal lobes, where conscious recognition of objects, faces, roots happens. And the another one is via dorsal stream, which takes information to posterior parietal lobes, where a 3D internal map of visual surroundings is formed, which tells us where objects are in relation to our body and in relation to each other. This map of conscious recognition of images from ventral stream is then sent to the frontal lobes, which chooses an object of interest among many objects around us. Frontal lobes also help us direct our gaze towards the object of interest. Once the decision of acting upon the information is made by the frontal lobes, the map created by the posterior parietal lobes is used to precisely execute the action with help of motor cortex and brainstem. Now, for this whole apparatus to work efficiently, we need to have a stable frame of reference like a stable tripod for a camera, which is provided by vestibular and proprioceptive systems. We also need to have intact cognition, which helps us understand significance of what we are looking at and decide what to act upon it. And motor system is needed to execute that action. Thus, what we call as vision is indeed a complex process involving several parts of the brain. And brain damage causing CP can involve any of these parts causing various manifestations of CVI. Now, all this is good to hear, but one tends to forget all of it when there is an actual child with CP in front of us in the clinic. It is actually an intimidating experience to see a child with impaired cognition who is unable to follow the instructions. Due to motor impairment, child is unable to respond to various tests that we perform. Due to postural issues, it is not possible even to make the child sit comfortably in the examination chair. Quite often they have poor fixation or eccentric gaze, and one struggles even to have a glance of the eye. Such children often tend to be irritable and cry a lot, and one wonders, how do I examine such a child? What we learned with time is that the problem here is not with the child, but with us. We need to educate ourselves about needs of such children and modify our environment to meet those needs. We need to work on ourselves to develop that patience and compassion to sit with such a child for an extended period of time, trying to elicit the desired information to help the child. In this effort, the first thing we must ensure is physical comfort. If child is physically uncomfortable, entire energy is diverted here and no energy is left for vision. Our regular examination chairs are not suitable to position such children comfortably. Our rooms are stuffed with so many things which create a lot of visual noise for the child. And due to such crowd, and as such due to crowd, our clinics are noisy. This entire sensory overload frustrates the child, and the only way child can express that frustration is by crying. So it is desirable to have a vision assessment room in a quiet corner of the clinic with plain walls and all test materials systematically kept in the drawers, and we take out only things that are needed at that point of time. We also can have plain curtains so that the observers can stand behind and peep through without distracting the child. We use this classical Indian sitting and also a chair depending on the level of comfort. We can also change the level of illumination in the room, making it mesopic or completely scotopic. We also have a tent of uniform color and minimal pattern to check if a child with poor visual awareness becomes more attentive when inside the tent, which cuts away all visual stimuli except the one being shown inside the tent. Now, just the way we create a minor operating room or a minor procedure room in the clinic, one can create a simple vision assessment room in the clinic. The next element in making the child comfortable is to understand how to hold a child with CP. Muscle spasticity or flaccidity, disturbed vestibular and proprioceptive systems, all of these pose challenges to position such children comfortably in the clinic for evaluation. Very few of our families are fortunate enough to have a proper CP chair, and our clinics also do not have any. We find these ways of holding the child effective. They give the child necessary physical comfort, feeling of safety and stability so that they can use their vision to explore the surrounding. For a flexed child, one can hold this way. For a stiff and extended child, one needs to spread child's legs on either sides of the mother's waist. And for a stiff and flexed child, one needs to put one hand in between the two legs, give child's front part enough body contact, and support the back with another hand. The other problem we often see is, why do the children tend to cry? One reason that we just discussed was sensory overload, which can be taken care by environmental modifications that we just discussed. Make sure that the child is well fed and rested before examination. Despite all that, if child cries inconsolably, there could be physical ailment causing pain to the child. Few common reasons that we saw often being overlooked are gastroesophageal reflux, many a times even requiring surgery or nasogastric tube feeding, constipation, poor nutrition causing irritability, poor oral hygiene causing dental caries, gingivitis, blocked ventriculoperitoneal shunts causing raised intracranial pressure and headache, infections like otitis media, urinary tract infections, pressure sores, spasticity itself can cause pain, muscle spasms following seizures can also cause pain. So if a child seems to be crying without an obvious cause, we should refer the child to a pediatrician to look for any treatable cause for the same. No vision evaluation or intervention is possible with the child being in pain. Now let us look at what is the role of ophthalmologists in helping such children. We have tried to categorize possible roles as must do, good to do, and ideal to do based on our experience. Under must to do things, first and foremost is making a diagnosis. Whether the visual impairment is due to an ocular problem or brain problem or a contribution of both, that distinction can only be made by a medical doctor, and necessary help can be made available only after appropriate diagnosis. Next comes treating treatable ophthalmic problems. It sounds very simple, but the reality is that many of the children either do not get examined at all by an ophthalmologist for years or do not get a complete examination due to reasons we just mentioned, or do not get treated, thinking that intervention is not going to help the child anyways since the brain is damaged. And this compounds their disability. The next thing that an ophthalmologist must do is good counseling. What a doctor tells the family in the first visit has a deep impact on how family looks at their child and their compliance with intervention plan. As ophthalmologists, we can take care of only limited issues. So we should refer the child to appropriate specialists in the town and therapists, since we cannot train vision in isolation. And while dealing with vision, we must take care that the overall well-being of the child is ensured. The next thing is about saving the children from pseudotherapies. We see several alternate systems of medicine offering cure for CP and CVI, and families spend their limited resources on these, and a lot of precious time is wasted. We should save children from such pseudotherapies. After this must to do, if one has deeper interest, it would be good to get into functional vision evaluation for such children, which forms the core of everything that is done to the child as intervention. As eye care professional, actually we are the most suited for this job, but it is not taught during our training. So one needs to train himself, learn from people who are good at it, just like the way we adopt new surgical techniques as they emerge. Just the way we have a dedicated day to perform surgeries, we can have some time dedicated for functional vision evaluation too. It's just about our priorities. What would be ideal is to make all therapies available under one roof in an eye clinic so that child gets all services without having to move from place to place. This facilitates communication among different therapists, which is otherwise a huge challenge. This is again something similar to having a visiting surgeon in your clinic for expertise that is not available with you. Again, it's about priorities. So everything is possible, including the financial aspect, if one plans it well. Now, when we approach a child with CP and CVI, we must have a framework of thinking to examine and intervene, just like we have a framework of thinking to approach a child with squint or glaucoma or any other problem. Let's have a look at the outline of the approach. In the first step, we should take a good history. What exactly bothers parents about child's vision? Any significant events in birth history? Have the treatable ophthalmic issues been addressed to? How is the child doing on different developmental domains? What are the systemic problems and how are they being managed? During examination, you would expect the child to respond to different tests that you do. So it is important to know how does the child communicate. If neuroimaging has been done, have a look at it to understand which parts of the brain are affected, which helps us understand visual difficulties of the child. Then we try to understand if child has any issues with motor system. Is there is hemiplegia, quadriplegia, spasticity, flacidity, what is it? How is the cognition of the child and behavior? Are there any sensory issues like hearing impairment, tactile hypersensitivity? Because all these are compensatory strategies that we need to use during intervention. Now, only after having gathered this background information, one should go for vision evaluation. If we jump on to assessing vision directly, one is likely to get lost and feel frustrated the way I did in the beginning. Now, while assessing visual functions, first question to be answered is whether the child has any visual awareness. If there is no visual awareness, track to be followed is different. If there is any evidence of vision, then we need to measure thresholds of vision for different parameters like visual acuity, field, color, contrast, using different tests that are available. After this, we do functional vision evaluation, meaning how does the child use vision for different activities. Here, we adopted structure described by Namita and Leah, dividing use of vision into 3 spheres of activity: vision for orientation and mobility, vision for communication, and vision for activities with sustained near task. The reason is that demand of vision for each of these domains are different. If a child can use vision for orientation and mobility well, it does not mean that he will be able to use it for communication also. And under each of these domains, we further grade the visual functioning as low, mid, and high level functioning. And each of these assessments are connected to interventions. We developed this pro forma as a part of our national program for child health, and hopefully soon it should be available to all to use. While assessing the child, one should make sure that whatever we assess should contribute to the intervention plan. And whatever intervention we suggest should become a part of child's routines with resources that are available to the family. Else, whatever assessments we do not mean anything to the child or the family. Also, whatever we assess should be explained to the mother or caregiver in a language that they understand and the way they can use that information at home. Same with different therapists who work with the child. Most of their interventions are vision dependent. And for those strategies to work optimally, they need to know how does the child see. I would like to take this opportunity to share a few more ideas with you. Number one is about vision stimulation. It is a popular practice to subject a child with very poor vision to bright lights in a dark room with no sound, no touch, in order to stimulate vision. We have seen such fancy rooms in top-notch hospitals investing loads of resources to build them. But the fact is that brain makes sense of the world around us using information coming from all senses. It is this integration of information that helps us to understand what is going on around us. And when one sense is compromised, contribution from other senses becomes even more important. The purpose of vision intervention is to engage the child in some meaningful activity, to learn something, to create a memory of that experience, which cannot be achieved by these colorful lights moving around the light, which carry no meaning. Actually, exposing the child to a sensory room is like shouting into ears of a hearing impaired child, hoping that that will improve his hearing. One of the review articles even says that such non-contingent vision stimulation in dark rooms should be abandoned, and meaningful activities involving multisensory experience should be encouraged, where the instructor carefully assesses the child's response to an activity and then tailors that activity depending on the response of the child to continue to engage the child to facilitate a more refined and applied use of vision. Now, similar to issues with processing of vision, children with CP may have issues with auditory processing. That needs to be considered while we do anything with the child, especially when we design the communication strategies. Many children with low functioning CVI may actually have difficulty in processing multiple visual stimuli simultaneously due to damage to posterior parietal lobes on both sides, which is called as balance syndrome. Professor Dutton has shown that keeping the children in a tent of uniform color and showing them single object can help improve their visual awareness, as seen in this child, who was unable to look at anything, and visual awareness improved by keeping him inside this monochromatic tent, showing him a single object to look at. And over a period of 1 year, he has significantly improved on his visual awareness even without the tent. And we also find this exercise very useful. And our parents design their own tents depending on the resources they have. Lastly, about apps. A lot of parents keep asking about any apps that can be useful for children with CVI. After using more than 200 apps, we found that these 6 apps are useful. But a word of caution here. These apps are meant only to improve visual awareness and visual attention. Once the child is better at those, we should switch to activities in real life and stop using these apps. So in summary, before examining, one should make the child and oneself comfortable. Before vision, try to understand child as a whole. There are few things that every ophthalmologist must do for every child with CP. and later how deep one wants to go is an individual choice. We also touched upon a few ideas about vision stimulation versus vision intervention, auditory processing disorders, use of sensory tent, and use of few apps on iPad. Thank you so much everyone for your attention.
Thank you, Niranjan. Excellent talk as always. And you have really briefed the role of an ophthalmologist in examining the child with a CP. There will be many questions later on. I would now request Dr. Banerjee to introduce Dr. Gordon Dutton. Over to you, Dr. Banerjee.
Hello, everyone. I can't see what's going on. Am I on?
Yes, sir. You are on, sir. Please.
Okay. Hi, everyone. It is an absolute pleasure to introduce my teacher, my dear friend, a mentor in many ways when I needed mentoring as a confused young ophthalmologist of 26, when we first met in the Western Infirmary in Glasgow, where Gordon was primarily responsible for running that world-famous program of 7, 8, 9 months to teach students from all over the world. And I think it's safe to say that Gordon has at least one student, if not very many more, in virtually every country of this world. I remember I first met Gordon in 1986, but 10 years later, we met up in London. And I remember Gordon and me sitting out in Hyde Park on one of those chairs that you could hire. And he was so excited telling me about the new work that he was doing. At the end of a 20-minute long narrative, I told him, Gordon, I can't understand anything you're saying. So we were both going together to attend a lecture I was giving in Moorfields Hospital. So he said to me, Barjot, you are in a completely different world and I'm in a completely different world. I think Gordon's world is far more rewarding, far more compassionate, and far more giving to those children and human beings who are so much less fortunate than we are. I'm looking forward, as all of us are, to hearing about Gordon's work in CVI. And Gordon, it's again such a pleasure seeing you like this, and even more so, seeing you so unexpectedly. And we would all be delighted to hear what you're saying to us and teaching us again. I sit at your feet once more, 30 years after I first did, and we look forward to hearing your lecture.
Yes, Dr. Dutton, now you can take over the screen. Welcome to India.
Well, Virgil, thank you so much for that kind introduction. And thank you also for those first two talks, which provide a perfect entry into this one. My talk is entitled Cerebral Palsy, Identifying and Acting on the Visual Difficulties Caused by the Related Cerebral or Cortical Visual Impairments. These words can be used interchangeably. Cerebral visual impairment, or CVI, has been defined as a verifiable visual dysfunction which cannot be attributed to disorders of the anterior visual pathways or any potentially co-occurring ocular impairment. And for over 10 years now, it has been considered a diagnosis integral with cerebral palsy as it is known to affect around 50% of cases. The key premises for this talk is that child development is dependent upon learning. But no one can learn from what they cannot perceive. And our medical role for cerebral visual impairment, for CVI, stops at diagnosis. It then needs to be replaced by our teaching role. Parents are the key educators, and they need to be supported and trained in small and salient steps by everyone that professionally they encounter. So as professionals, we all need to understand the child's limitations as a profile to work within, and the child's abilities as a profile to make best use of, recognizing that learning requires access to information. It requires the cerebral, visual, and other impairments can impair this access. We need to recognize that. And this means that each specific impairment caused by cerebral visual impairment must be found, identified, and its limitations to access to information identified and always worked within. And in the context of the child's profile of abilities, these include their visual skills. We need to identify what they can do, not just what they can't do. We need to identify their hearing and their language skills along with our colleagues in team work. And of course, we need to identify their motor abilities, not just their disabilities, so that they can learn to make best use of their own worlds. And we need to identify their social skills and help that development too. So with this information, we can inform and teach the parents, that's all of us can teach the parents what can be seen and what cannot be seen. So that it cannot be learned from, and how to adapt to their child's world to enable their child to learn and to develop. So with CVI, what aspects of vision may be limited and need profiling? Following on from Niranjan's talk, my way of thinking is similar, and is to consider the salient visual brain structures, starting, of course, with the primary visual cortex. That is where the imagery is formed. So for central visual function, we need to assess the functional binocular visual acuity, which can then be interpreted for the families and relatives and friends as the measured line and gap widths needed for all imagery at salient distances to easily access information. I've always provided a felt tip pen of that line width, telling the parents to go through all the child's books and make the eyes and the mouth and the nose visible when they weren't visible before, because we've just measured that they'd not been able to see them. And at what distance is eye contact gained and maintained, so that one can always stay within that distance, because without it, you can't communicate. We need to think of the functional contrast sensitivity, which is the level of contrast needed to easily access information, not the limit, but the functioning limit. And what degree of contrast is needed to allow faces and facial expressions to be seen. Although not much is known about color, we need to find out what colors and color contrasts are best seen and discriminated. And then it moves on in the occipital cortex, which areas of the visual field, the peripheral vision, and the attentional visual field, which comes to the posterior parietal lobes, which can best give access to information. Are there lower visual field impairment present, hampering movement? And what needs to be done to cater for this? So which areas of the visual field and the visual attentional field give best access to the information? And then we move on to the middle temporal lobes, which weren't mentioned, but they are just in front of the occipital lobes. And that is the area responsible for seeing motion. And of course, our whole worlds are always moving. As we move through the world, everything else moves in the opposite direction. So is perception of movement limited by injury to this part of the brain? That is called dyskinetopsia. And if so, at what slower speeds can information, meaning anything to learn from that moves, communication, meaning the movements of the face and gestures, and mobility, as you move through, what moving hazards might there be to be seen? And then we need to think about the posterior parietal lobes. These map the world as has already been outlined. And they map the world so that we can search the world and so that we can move through the world using the picture in our minds, which is an emulation of the world outside through which we move in order to get our limbs to their destinations. So it's not just a motor problem, is it a visuomotor problem? Our worlds are created by our posterior parietal lobes in real time as a non-conscious 3D mental emulation of our surroundings that allows vision to guide our movements and to give the framework for the conscious visual scene created in the temporal lobes to be mapped both with respect to ourselves egocentrically and with respect to the world around us allocentrically. Now, this has been known since 1918. When Gordon Holmes studied 6 soldiers where shrapnel went through their brains from the First World War. And here is Sergeant K, who's got a bilateral lower visual field impairment from a parietal pathology and also was only able to see 1 or 2 things at once. And when he said about the world, he said, I could see the things I can see clearly, but my feet do not know where that step is. He had impaired visual guidance of movement or akinetopsia, and he could also see nothing that moved. So we need to recognize the resulting spectrum of Balint syndrome, which is the severe element, to the mild dorsal stream dysfunction. And with Sweta Philip, we've published a series of cases from India where the posterior parietal lobes are afflicted in each of these 4 pictures. The ring has been slightly moved, I'm afraid, but where you can see a focal injury to that area of the brain. But of course, remember, it's also commonly afflicted in cerebral palsy too. We've mentioned periventricular white matter disease. And in the periventricular areas is where this white matter is. This amazing work from 2016 shows a sighted control on the left with the dorsal stream, which anatomically is the SLF or the superior longitudinal fasciculus that I'm moving my arrow around, which takes the picture from the occipital lobes up into the posterior parietal lobes and then to the frontal lobes where we know what we are looking at. And then the ILF, the inferior longitudinal fasciculus, which takes the information to the temporal lobes and then up into the frontal lobes so that we can recognize things. And as you can see in the ocular blind, they have all these pathways. And therefore they use alternative ways of knowing and understanding their worlds because these pathways are redeployed. But in cerebral visual impairment, these are not, because they are much smaller, much thinner, far less can be seen. And this explains how only a small amount of stuff can be seen, or simultanagnosia. And fewer objects might be recognized if this bundle is afflicted. Often it isn't. Often it's only this one in cerebral palsy, and often this one can be intact, but sometimes it's not. So every child with cerebral visual impairment has their own independent, separate, unique pattern that needs to be profiled. So let's think of simultan agnostic vision. This picture was made for me by a lady who has it, and she said, I only look at the man and this is what I see. Not being able to give attention to the rest of the scene, singularity of Balint syndrome. So we need to think then, what are the limits to clutter and crowding? How much clutter needs to be removed, as in that terrible light room with all those lights on, when only one light is needed on the mother's face to make her exist as a singular entity in somebody who's got profound cerebral palsy, quadriplegic cerebral palsy. And so also, how accurate is visual guidance of movement of the upper and lower limbs, recognizing that this is not just motor, it is visuomotor. And is this better in the upper visual fields, knowing that the lower visual fields are commonly restricted as well? Often reach is better there. So let's move on to recognition. We do this by comparing the incoming images from our eyes with our library of images inside our temporal lobes, as in this case with hydrocephalus afflicting both dorsal and ventral streams and occipital lobe. So here is a picture of the right temporal lobe, where the fusiform gyrus, where faces and roots are stored. Ever realized that you don't recognize somebody in a place that they're not supposed to be in? That's common because they're cross-filed together. So that recognizing, can faces be recognized even though the acuity is good enough? And again, at what distance? And in what degree of crowding? Because it could be a low acuity, or it could be due to a degree of crowding, meaning that only one can be seen. And do facial expressions have meaning? Again, at what distance and at what speed? Because it could be a speed issue. And at what degree of crowding? It could be a crowding issue, which is making this child appear to be autistic, appear not to have theory of mind, because we are judging them by our own vision, not theirs. And how good is route finding out and about and at home? And then thinking about the left temporal lobe, which sees geometric shape. How good are we, is the affected child at being able to see objects and shapes and even letters, recognizing that language and words are also interpolated further forwards in the left parietal cortex. So remember that, like cerebral palsy, cerebral visual impairment is a lifelong journey within an alternative state of normality. And in this context, what models of thinking do we as professionals need? Behaviors in children with cerebral visual impairment can be adaptive when they compensate well. They can be reactive when they're overwhelmed, and absent when they cannot see. So while parents need to understand and adapt and cater for their children's needs as well. So we need to always recognize this and work with this framework of understanding. So let's develop this theme with some examples. This picture by Lennox et al. Was one of the early and one very important paper on the lower visual field impairment in children with spastic diplegia who have periventricular white matter pathology, cupping of their optic discs due to transsynaptic retrograde degeneration, lower visual field impairment, which is subtle and may not have been detected unless it was really sought out. And that will come back to that shortly. So with lower visual field impairment, that table may not be seen. And so if it's moved, might be a problem. And then the adaptations to lower visual field impairment is when going downstairs, for those who can, they do it very carefully. They often slide their heel down the riser to be able to judge the height. They hang on to the banister. It might not just be motor. They might feel with their foot to check whether there is a step present or not because they don't see it well. They may lie on the floor upside down, watching the television in their upper visual fields as a very clever adaptation, not as an eccentricity. They may go down a slide head first to use their upper visual fields to see where they're going. They may push a plate further away in order to be able to find the food on it. And they may hold a book up in their upper visual field in order to get down to the next line, which might not have been visible. What about reactions to the lower visual field impairment? For those that are mobile, they may be very reluctant to jump off a bench, very reluctant to jump into a swimming pool because they jumped onto somebody's head they didn't see before. They may hate it when a table is moved because they've mapped it before and get very angry, understandably. They may hate going over floor boundaries because they don't know whether there's a step there or not. They may hate going over edges of pavements, tripping as they go. And ball games where there's a fast ball on the ground that's invisible are totally reprehensible. They make no sense whatsoever. And then there's the absence of behavior due to a lower visual field impairment. All those toys fell down, but once they've fallen into the blind field, they can't be found again, can they? And yet such a child, if they can stand, will play for ages with their toys looking up on the kitchen table. They may leave food on the plate. They may leave shoes on the ground. They may get very scuffed shoes. What adaptations to simultaneous agnostic vision? They may get very close to the television, if they're allowed to only see one or two things at once. They may sit behind somebody looking up in their upper field because they can't look at a face and listen at the same time because that is too much information to process. They may look away when having a conversation rather than looking at you in order to hear the sound. They may place a toy on a plain background and not a patterned one in order to find it. They may line toys up, not because they're autistic, but because they can find them again by one-dimensional search. The parents may have adapted to this by making a plain room, by having a clear floor, by having a compartmentalized plate so food doesn't overlap, by having a high shelves where they can store possessions in an intact upper visual field, by having search in one direction in these compartmentalized things in wardrobes, by having a book stand. I've been taught all of this by parents. They may react to simultaneous agnostic vision by only being able to light gaze, because that's competitive simultaneous agnosia. They probably can't see more than one thing at once. So that's a really useful clinical sign. They may look down at the floor because they can't look up because there's too much to see. They may hate being in traffic and be terrorized by it. Walking in crowds may be very frightening because they can't tell where people are in 3D space, and they may coil back in terror as people approach because they can't map them in 3D space, which is the flip side of impaired visual guidance of movement, impaired mapping of the movement of others, not knowing where they are, frightening. We can adapt to this, we can understand it. So quadriplegic children, as already been mentioned, often have marked posterior parietal pathology. And this boy, for the first time, looked around inside this tent. So the impact of being surrounded by a tent can be phenomenal for those that have profound simultaneous agnosia because their pathology of their parietal lobes extends further back into this mapping area. And this can have a major impact on language learning, because if you can only see one thing at once and you've got low speed of processing, then only what you are looking at or feeling is what you know of. So this boy, this 6-year-old boy, started to learn language for the very first time when he was given single items to handle and single words to label those items. It was we who were wrong. We need radio and not TV, child-centered communication about everything. Just think of the radio for cricket. It makes sense, but that's not normal language. But they need this radio language all the time. It's essential. Think about their behaviors to temporal lobe pathology. When it comes to being able to recognize faces, they may not do so. Find people, be able to route find, and be able to know objects and shapes. And so the classical clinical approach concerns threshold measurement. It concerns the key ophthalmic approaches of anatomical diagnosis, pathological diagnosis, neuro-ophthalmic classification, and an understanding of the visual brain that this brings. But this does not help the child, because we need to take this forwards in communication, as Niranjan just told us. So let's wait. Children can only learn from what they can perceive. They cannot learn from what they cannot see. That's obvious. So developmentally, there's an issue, and neither can you if you make this material almost invisible, which I have for you. It's exactly the same slide, but almost invisible. So the key needs of the child are visual and auditory, to be accessible, to be learning and teaching, the developmental needs, their behavioral needs, their emotional and psychiatric needs. And this needs a team effort. Vision facilitates mobility, it facilitates access to information, it facilitates social communication, and children need to learn all these skills. 85% of their time is spent with their parents, even in mainstream school. So what do children with CVI need? To help them learn to develop optimally, to thrive and to succeed, their parents and their teachers to learn their theory of mind, their limitations and their strengths. But to what extent are we all self-referencing? To what extent do we not have the child's theory of mind? To what extent are we autistic unto the child? And how can we rectify this? By seeing through the child's eyes and helping others to do this too. So think about this. You might be interested now, if you have a camera, to photograph this just now off the screen. This is our simulation of simultanagnosia on our website, CVI Scotland. It shows that simultanagnosia gets worse under conditions of stress and conditions of crowding. And these are opportunities for to be able, with Sight Sim, which you can get by scanning these two things with your own iPhone if you want to. You can find Sight Sim to simulate acuity, that's my bell, and you can use this also to simulate acuity on peak vision, because Sight Sim works on computers. Peak Vision is an app for your phone. So those are our books that we've published over the years, and I commend you our website, CVI Scotland, and a CVI Society website. And on CVI Scotland, if you want to have further lessons as paramedical professionals listening to this, you've got 51 talks from me, which you can find under lessons on CVI Scotland, each about 2 to 3 minutes long, which I hope you enjoy. Thank you. Here's a view of Scotland.
Wow, that was great, Dr. Gordon Dutton, and you helped us see the world through the eyes of a child who has CVI, and that's indeed a fantastic experience for all of us. I would request Dr. Firoz Mehta to give a vote of thanks to Dr. Dutton.
Gordon, you can hear me?
I can indeed, Firoz.
Yeah. Gordon, that was as brilliant as anything I've ever heard. And you have lost none of your teaching skills that I fathomed, I understood, and learned from you 30 plus years ago. Ladies and gentlemen, I met Gordon Dutton many, many moons ago, but I never found a better teacher than Gordon in my life in ophthalmology, which is now reaching its peak almost 35, 40 years later. But there was none better than Gordon that I have ever met. And it was a great pleasure to have learned again from him all these very interesting aspects that he has spent his life working in. But to make it a little interesting, I'll just diverse a little from what Barjor already has mentioned of Gordon, that Gordon's better half, also a consultant ophthalmologist, had Indian upbringing because she was a daughter of Scottish missionaries in the middle provinces of India. And she grew up in India and then went away to Scotland to become a doctor and an ophthalmologist, and later married Gordon Dutton. And therefore, Gordon spends quite some time visiting India because Kirsty needs to see her friends, and therefore Gordon is seen around. And I'm sure we people should make more use of Gordon's skills and teaching abilities when he comes around to India. Gordon, a lot of friends of ours from Bombay have wished both Kirsty and you lots of love.
Thank you.
Thank you, Dr. Firoz. We'll now move on to our final speaker, Dr. Namita Jacob, who is a PhD from UC Berkeley and an international consultant for development of systems and services for people with disabilities. She is the director of Chetna Trust and Inability Foundation at Chennai. She is also a senior education specialist at the Perkins International School. She has authored several books and worked extensively in rehabilitation of children with sensory impairment. She'll be speaking to us about rehabilitation of children with CVI. Welcome, Dr. Jacob.
Thank you. Just give me a second to share screen. Is that right?
Yes, Namita, absolutely. Just make it full screen. Yeah. Go ahead.
Is that fine? Thank you so much for having me in on this conversation, in this discussion. I'd like to salute particularly this holistic vision of Dr. Johari, which drove the creation of this group in the first place. It's lovely to speak after a panel such as this, where we have a brilliant setup by Dr. Niranjan, who helps us understand as ophthalmologists in a very realistic Indian situation. Yes, it is possible to be more responsive to the needs of children with cerebral palsy. Dr. Dutton, as always, beautifully sets up all my talks with his strong call to watch the child and to listen to families, because often solutions are already in place and perhaps just not recognized or acknowledged by all of us. You can see I've titled my slide Alive versus Living. And for me, this is really, really important that we understand. Yes, always for all children, all adults, all people. Being alive, yes, means just having life, but living means your active participation in life. And this ultimately is our responsibility. Too often we spend loads of time searching for a future reality and forgetting today, particularly in cases of people who have cerebral palsy, where there are so many conditions and so many things you might think need to be fixed. You might want to think about this. What is their quality of life today? And what are you doing to ensure their quality of life today? All professionals have a primary responsibility, and ours in rehabilitation is to focus on ensuring a meaningful participation in life. And the role of the environment in limiting or enabling this participation is enshrined in the ICF, which has numerous areas of functioning. Cerebral palsy brings particularly special challenges, and these are important for us as professionals to understand if we want to provide appropriate rehabilitation support. What are these special challenges? Cerebral palsy is a primary involvement of a foundation system, one that affects balance, it affects posture, it affects coordination, and makes what we consider normal in life, that we use to guide our intervention, fundamentally different. Typical assumptions that we make when we direct distance, when we make recommendations, think about distance or time or effort, are no longer completely valid. And as Dr. Dutton says, pay attention to each individual and their experience of life. What does this person actually need to see? How far away from their eyes is this actually? What is the angle of view? How quickly is this person going to be tired? You need to factor all this in when you make decisions and you provide guidelines or interventions. Participation in the simplest of activities brings challenges that are specific to cerebral palsy. Related to the condition itself, for example, is a difficulty in recruiting and sustaining attention. Multiple systems, you can see, are involved in the simplest of activities. A child needs to hold her balance. The child needs to reach, grasp, give attention, maintain posture. Many of these systems are involved. Many of these systems are going to be impaired. What we often forget is the barrier of attitude, and the barrier very present in our environment. Negative attitudes, inadequate knowledge often mean that children don't even have an opportunity to play. The vision and motor system are closely tied in early development. In both systems, much of development happens post-birth. While both come with a strong internal wiring that push development in certain directions, they are also heavily influenced by the experiences provided to them. Look at this child trying to pick up sunshine from the floor. Motor experience texturizes vision. It helps children understand the information coming in through their eyes and makes it real for them. Touching, holding, feeling, manipulating, moving yourself, climbing onto and under and into things. This is how the brain starts to understand visual nuances of texture, size, differences, distances, and dimensions. Through our lives, when vision is unclear or unreliable, like waking up in the night, if you want to go somewhere or get something, it's touch that you will rely on. What we tend to forget is that touch, as a sensory system, is automatically impacted in children with cerebral palsy. To me, having an impaired visual system when you have cerebral palsy is complicated hugely. It results in what I would consider a unique and different impairment, deserving of its own category from a developmental and learning standpoint, VICP. The requirement for support cannot be solved by just picking a child and sending them to physiotherapy and sending a child to vision rehabilitation. It is not additive. I fix A and I fix B, therefore I have fixed AB. Does not work. Why is this? Let's understand for a moment the impact of senses and sensory information. All the basic concepts that we form in life come through the information that we receive through our senses and our engagement, our response, our ability to respond and to check this information. What we forget is that this happens different concepts such as an understanding of ourselves, our bodies, our abilities, our self-perception as individuals able to interact or act on our world, our understanding of ourselves as being separate from things and other people, our understanding of emotions, context of events. All these things happen with different sensory and motor systems in combination. You see here, I've arranged the different senses in a sort of priority list. Our understanding of things, for example, you get a lot of information visually, you double check it haptically with touch. And auditory is a good recognition, but it's not a good learning source. So also each of the concepts. We rely on different senses and different combinations of senses to give us this kind of concept. So what if I lose both vision and have an impaired touch system? I'm left with auditory. This is not a great scenario. You can see that several concepts are going to be fundamentally difficult for me to access or fully comprehend. When we consider significant areas of functioning in children, the ICFCY lists 9 areas of functioning, but I like to think of these 4 specifically in the context of vision and learning: social communication, purposeful movement, play and exploration in near space, and literacy development, where vision is so important, especially in the absence of touch. When planning rehabilitation, it's important to remember that each of these different areas rely on efficient functioning of different combinations of systems and will therefore place a different weight on the abilities of the child. You must create a map based on a child's capacity and experience to see where the challenges lie. We tend to think of intervention like a linear sequence. Increasing functional capacity equals an increase in performance, which equals an increase in participation. And this is not that simple. It's not wrong, but in children with complex sensory needs, the ask of a situation really needs to be considered. In these multiple social communication systems, you can see the demands on both the visual system and the physical system is going to be profoundly different. Therefore, a child who is able to participate visually in a one-on-one situation is going to struggle in perhaps a situation in a playground or in a marriage hall. So how do we think about this? How do we plan? When we plan for increased participation, we enable an immediate change in the way a person engages in the world, and it shifts how they think of themselves and how the world thinks of them. And this is what I mean by focusing on the now. In any activity, we identify what captures the essence of participation. In this situation, for example, we want active interaction, listening, responding, looking between object and person. And we should identify limitations brought by the condition. For example, tone and balance in the presence of emotion. Laughing and excitement raises tone, leading often to a loss of balance and a loss of control over visual focus. So think about who will be present. How does it impact a person emotionally? How long is this activity going to take? What barriers and supports will they have from the physical environment, the social environment? Sometimes the solutions are evident, and sometimes you really have to be creative to enable participation. But mostly, if you really watch children and if you really listen to families, you realize how well they already do this. They may not always be able to explain why it works, but I've learned some of the best strategies from parents. When they are stuck or when a child is stuck, being systematic in your process of thinking helps. So here's an example. This is Anthony, who's about 2 years old. He has cerebral palsy and visual impairment. This much is evident just by looking at the child. This is the reality for most of us. Some records exist, they are illegible, they're in an unclear language. The child has been taken to the hospital. The parents are not quite sure about all the terms the doctor has used. So we have inadequate information, but we do have a child and we do have a concerned parent. A quick assessment that I do, this is in the child's home. I realize that if I can't help the family view this child differently, he is already at very high risk for many things. A good place to start is with the situation or the activity that is valued by the family and likely to succeed. They need to think differently about the potential and the experience of this child. As I listen to this mother, I hear 2 topics that you see written on the top of the slide. One, her 2 sons, the older boy who's 3 and this little boy who's 2, don't play very much together. And she wishes that she could leave them for an hour so that she could turn to other jobs. Now, this neatly fits into an opportunity to work on vision in social communications contexts. Playing a bit with him, I see that he has numerous areas of delay for any kind of two-child play. When he's well supported, I get visual attention to my face when I'm about a foot away and to a large colorful object at the outside edge of about 2 feet. So I now have my visual boundaries. I quickly look across these 3 parameters. How robust are his visual functions? How available is his visual system? Do I have to elicit visual attention, or does he use it voluntarily? And if so, for what? Because these are the elements I'm going to use in a situation largely driven by a 3-year-old child. And finally, what elements can I put together from the environment to ensure that he can easily use his vision? Keeping these major goals in mind, I create a very simple game to put his older brother in charge. Eye contact, sustaining, maintaining, and paying attention to expression becomes a key part of the game itself. Anthony must work on maintaining and switching attention between face and object for him to be able to play this game. Lots of motivation because he loves his brother. I need to pay attention to the fact that he's going to lose control over his body when he's excited. So I place them in a bowl shaped, a basket chair that will keep him flexed and supported. The choice of the soft toy he's holding, the choice of the big toy that his brother's holding, and the way I position both the boys, all planned to ensure success. And this is very, very key. Success and fun, 2 extremely key elements to seal learning and motivation into an experience, makes it last far beyond the activity. Children view themselves as being able to see. And this is a gift, especially for a child with CVI. I want to leave you here with a very important message. I think Dr. Gordon said this so strongly and so beautifully. We often see things from our visual experience. And what is really key is to start to understand how we can experience the child's perception of the world. I want you to think for a moment of an experience that many of us have had. When you drive along in a car and you switch from listening to music to listening to news, you immediately change the tuning because now you want to hear the speech clearly. You probably lift the volume because you want to use less energy on hearing and more energy on listening and understanding. If your windows are rolled down, so the topic, pay attention to the topic. If your windows are rolled down and there's noise on the road, you immediately turn the volume up a bit more. Why? Because distractions make it hard for you to pay attention, and that was your topic, right? Imagine now you're in a traffic jam. Imagine that traffic has become more Indian-like and crazy. As the difficulty of the other tasks increase, your ability to pay attention to the news is going to reduce. And you're going to have to pull up your window or increase the volume or stop your car if you really want to get what you started out for. So pay attention and adjust the visual volume of whatever it is in that experience that is key for the child to have. And don't forget, over a period of time, and with the addition of each factor like emotion, excitement, worry, stress, and personality factors like self-perception, the weight on the child, the difficulty that the child is facing is going to increase. So if you do want to ensure the joy and the ease and the success, you're going to have to be very, very good about continuously adjusting visual volume until children learn to do it for themselves. I'd like to conclude reiterating the main points I've made. In my mind, in rehabilitation, you cannot do vision separate from understanding the child has cerebral palsy. You have to see the child as one individual with all the difficulties that they bring into this equation, all the strengths they bring from their personality, all the worries they bring from their own self-perception. Visual intervention is therefore more than training visual functions. Early success. So pick your first activity smartly. Early success helps develop internal value or vision. Do not underestimate this as an important thing. Those who see themselves as being able to see will try harder because they expect it of themselves. Attitude and environment are powerful and underused supports. Spend a lot of your time and energy helping the people around the child and helping the child learn to see themselves, learn their own strategies. Appropriate intervention changes life now as well as in the future. Do not undertake intervention that only looks at tomorrow and forgets that this is a child alive and functioning today. With this, I'd like to stop and give you again CVI Scotland. I love this website because it shares the perspective of the person with the condition. Layer test for those of you who have questions around good testing tools and testing processes. And our own website, chetna.org.in, which provides resource materials that could help you in your work. Thank you.
Thank you, Dr. Namita, for that very passionate and enlightening talk. And I would request Dr. Kruti Shah to introduce the next speaker. And after the next talk, we have some time for question and answers, and we have a lot of questions. So, Kruti, over to you. Kruti, are you there?
Oh, sorry, it was mute. Sorry. Yeah. So today we have a proud parent, Mr. Malinath, talking about his 7-year-old child with cerebral palsy. The child was diagnosed with myopic astigmatism and CVI at age of 5 years, and the mother has been the sole caretaker. He would like to talk to us about how timely interventions and efforts have changed his son's life. So, Mr. Malinath, over to you. Please go ahead, sir.
Okay. Thank you, Dr. Kriti Shah, for the introduction. I am joined here by with my wife. She is Madhavi. And hello to everyone. After listening to all the screen size, I think is small, so she's beside me only. After listening to all the presentation, our heart and mind is wishing that we had the same web seminar about 6 to 7 years ago, when my son was about 1 year. The thought is because that time we needed knowledge. Now we have some experience and we are also courageous enough. We took some courage to come forward and try to tell the experience of what we have undergone for the benefit of other children. Dr. Kriti Shah has already introduced my son. I'll not talk his ocular parameters. When my son was about 2.5 years old, that is when we visited Dr. Johari's clinic. He is an orthopedic surgeon, for people who don't know. In that clinic, there were many pamphlets sharing the importance of vision, CP, everything. While we read all those vision things and other things, it took us full 3 years. For 3 years, we never visited any orthopedist, though Dr. Usha Johari was also within the same floor. And after 3 years when we went, then all the diagnoses that just now Kriti Shah doctor has told, those things have been told. So, okay, we were also aghast slightly. But basically what was happening is we as parents were constant denial mode. We never thought that there is something wrong with all his eyes. We were believing that we had other complicated issues, Botox, hip surgery, leg length discrepancies, not touching ground, this heel of his not touching the ground, then how will he walk, when will he walk. So visual impairment has taken a backseat. And that was one small mistake or a big mistake that we do. It was not ignorance, it was basically that we were in a denial mode. So did we miss something because of that? What we missed was this visual impairment was diagnosed at age 5. At the same time that a lot of complicated problems of hip and other things were also diagnosed. So we had to do between 5 to 7 years, balance both the extremities of physical impairment as well as this visual impairment. Whereas at the age of 2 to 5, when he was free, he was just doing PT. That time, if we would have gone to the eye doctor and we would have got it detected, we would have had more time. This is one mistake that we did. And it was difficult to manage both the legs after that. That is now behind us anyway. What we could have done better is that, for example, I just give one small example. When we used to go to the physiotherapist for getting better hand-eye coordination, they used to tell that, okay, we will stretch his arm and then push his range of motion. We were also very happy to look at that range of motion, and but we never went to a visual therapist. If we would have gone to a visual therapist and increased his hand-eye coordination movement, his range of movement would have automatically increased. So this is what we did not do better. Am I audible?
Yeah, you can continue speaking.
Okay, sorry. I was seeing something else on the screen, sorry. So though late, there is some improvement. For example, what are all the benefits that after doing this visual therapy impairment and the physical is that we keep going to the eye clinic every 6 months to 1 year, 3 times in a year. Earlier it was yearly once, now it is 6 months once. What we saw is, for example, when he watches TV, earlier he used to watch TV for the sake of watching. Now he is able to follow. He used to say 10-13. 10-13 for him is actually 101 for 3. Now he says 101 runs, 3 wickets. He's able to follow the score. He's able to follow who's batting, the names, other things because of the visual intervention that we did. When he's writing in the school and other things, this letter B, which is because he's got a lazy eye in the right side. He used to write B, but T was a problem for him. Slanting T and not in the... Those alphabets, writing and that fine motor things have started slightly improving. Now he is able to write letters and numbers within the boxes or within the lines and all. Now, are we as parents, what is it that we are keeping our fingers crossed now? Now he is about 7 years, 9 months. He'll be about 8 years in another 2-3 months. So what is it that is in the back of our mind is he still has bifocal issues. So his right and left images are slightly different for him. So now when we talk also, he looks between the forehead and the rim of the spectacles to look at closer images. So for that, they suggested to have round this Harry Potter type glasses. That is what we are doing. We are doing patching and other things. So this is what we keep doing. And are we having any constraints? Is it I don't think our story is so great, but even in a place like Mumbai, we find that there are shortage. There are a lot of PT, OT, SI therapists and all, but not many visual therapists. Wherever we went, we ended up actually going to meet the eye doctor who always gave some numbers. So this is one help I want from the medical fraternity. And I'll just 2 minutes, if you give me, I'll introduce my child about whom I'm speaking. He is Madhav. He is my child. He is... Mother, can you say something? Yeah, tell.
What?
Okay.
Hi, Madhav.
Hi, Madhav.
See, he watches like this.
Hi.
So he is the one for whom we are trying to put, and thanks to all the doctors, right from Dr. Mother, do you want to thank anyone? Okay. He's shy. So right from Dr. Taral Nagda to Dr. Usha Johari, Dr. Ashok Johari, Dr. Medini Pandi and all, they helped him all. Medini auntie, he calls him. So we thank all of you, and on behalf of my family and all, this is what as parents we have to say. And thanks for giving this opportunity in such a big platform for us. Thank you.
Thank you, Mr. Mallinath. It was very enlightening to see a parent's point of view. And to be frank with you, most of us ophthalmologists are also still trying to understand your child's problem. So, because this problem is such that not many people understand it very well. That's why we are having this seminar, so that more and more people get a grasp of it. And so that in future, children like your child can be helped in a better way.
We love.
Thank you very much.
Thank you. Thank you.
So that was a very wonderful session, and I would move on to the question and answer session now. In the interest of time, I will post, we have a list of questions here. In the interest of time, we will post one question to one speaker, whom I feel is the most appropriate person to answer it because of the nature of the talk that they have given. And if the time permits, then we can later on have a discussion on it. So the first question is Dr. Niranjan. Dr. Niranjan, are you there? Please unmute yourself.
Yeah, yes, Siddharth, please go
So
ahead.
the first question is to you. Are there any tips on how to reduce chair time when examining a child with CP?
Well,
this is more or less contradictory to what you said, because you said, first of all, don't put him on the chair. So the question, yeah. So any tips on how an ophthalmologist can help in his own setting?
Okay, so few things that I have tried is like, if you already know the child is coming to you on a particular date, ensure that you have the background medical information beforehand through email or whichever way you try to gather the medical information. So you take less time to document history. Tell parents that the child should be well fed and should be well rested before they come to you. And when the child arrives in the clinic, try to take them inside as early as possible without having to make them wait in the waiting lounge, because that again makes the child irritable and reduces his patience. So these are some of the ways by which we can ensure that the child is comfortable when he arrives in the examination room. And as I said earlier, to get a better cooperation and reduce the examination time, we need to go to a different place and not to our regular examination room.
Dr. Niranjan, do you ever use videos that parents bring, or do you ask them to make videos at home to help you reach your diagnosis?
Yeah, certainly. We do that quite often because the situation in the clinic is quite artificial one and unfamiliar to the child. So the responses that we get may not be the one that parents observe at home. So we always encourage parents to take videos of the routine activities of the child and show to us. That gives us a lot of information. Ideally, we should be visiting children's homes and observe them in their familiar surroundings. But because of logistics, it is often not possible. So these videos help us a lot on that front.
Okay, thank you, Niranjan. My next question is to Dr. Dutton. Dr. Dutton, the question to you is that, are there any specific bedside tools to measure functioning of dorsal and ventral visual functions? Can you measure dorsal and ventral visual functions in any way?
The best bedside tool is in-depth history taking, if you call it a bedside tool, because you need first to, the way to access this information is to find out about what is seen and what is not seen, and to ask the questions. And for that purpose, we have a published set of over 50 questions, which enable you to get straight in and find out whether there are dorsal stream problems. Dorsal stream problems are the commonest. And so the key issue first is, does the child trip? Because you're looking for lower visual field impairment first, because if they've got lower visual field impairment, they've got posterior parietal pathology. So, and then is to get the child, if they are mobile, to see whether they can see their foot when they lift it, because that detects a lower visual field impairment. If there's a lower visual field impairment, there's a 50% chance of a dorsal stream problem. And that is typified by inaccuracy of movement. And the key is, when you are just, a child is reaching for something, watch the hand as it reaches out. If it reaches out accurately and is orientated accurately, then there is no optic ataxia. But often, especially in cerebral palsy, of course, but the hand may well have much wider in-flight gap between the finger and the thumb and the fingers. And also the item might just be grasped from above or gathered up. Those movements are telling you, oh, there's posterior parietal pathology. And then think about whether or not the child, how many things the child can see at once. The question is, can they see their parent in a group of parents? Can they find a toy in a toy box? And then, of course, if you have a box of toys, ask them to find that toy and see how many other toys they can find it from amongst. Those are the key issues.
Okay, so the key is observation and history taking. That is how you will reach a diagnosis.
I mean, neuropsychologists in Europe would say we need to do in-depth testing with lots of equipment, but that resource of neuropsychological testing is not available in India. So in essence, these methodologies are extremely effective at getting straight to the bottom of and also if there's cupping of the optic disc that shouldn't be there, that's telling you there's periventricular white matter pathology, probably. And of course, it's not a bedside tool, but imaging of the layers of the retina will tell you whether the ganglion cell layer has had retrograde transsynaptic degeneration. That's something for the future. OCT.
Okay. While we are with you, I will post you the next question, which is asked by another listener. Do children with autism have any cortical vision impairment?
That is another 4 hours of lectures.
So there we have it. But a short answer, yes or no.
Imagine a Venn diagram with two circles.
Yes.
You have the circle of CVI and the circle of autism. They overlap. Okay. So yes, there's a mixture. And then within the CVI circle, there's a circle of people with autism because they've been misdiagnosed. And within the autism circle, there's a circle of CVI because they've been misdiagnosed. That's the diagram.
Okay, so the short answer is yes, they have. Okay, I'll move on to... Yes.
But they're not mutually exclusive.
They're not mutually, and some will have and some will not have. So,
yes.
So my next question is to Dr. Namita Jacob. If you may unmute the mic. As an ophthalmologist, if you see a child with CVI, who is the best person to refer him to for therapy? Is it an occupational therapist? Is it a physiotherapist? Or is it a vision therapist? In absence of a vision therapist, who is the next best person?
I'd probably be lynched for saying this, I guess. There's no answer that's going to save me here. But in reality, I would probably pick an occupational therapist because perspective-wise, they have the right focus, which is on enabling functioning. They have an understanding of the sensory system and how it interacts for each individual. So probably that's your best bet.
So an occupational therapist can substitute a vision therapist if there is nobody.
Yes, assuming they've gone back to their notes. In all honesty, all of us in our professional development, in the course of our career, in the course of our trainings, we've all done a segment on cerebral palsy. And we know, in fact, much of what we've covered in our lectures and our discussions. We've just never been called upon to apply it. So we all learn the structure of the brain. We all know the percentage of children, visual issues in children with cerebral palsy. I'll tell you from my college in the 80s that I already knew this. And yet, I will tell you how many children I missed until it kind of leapt up and hit me in my face. So I do think that all of us are given much of the foundation information. We have not done our jobs. So all of us hold in us the potential to be smart, to be perceptive, to really respond. It's up to us. You don't have to be this or that or the other profession. I am not a vision therapist. I'm not by training. I'm not an ophthalmologist by any stretch of imagination. I'm not most of the things you probably assume I am. So if I can do it, all of us pretty much can. It's about taking the time to learn and taking the time to watch.
Okay. Thank you for that wonderful answer. My next question is to Niranjan, going back to you. What do you see in these children when they are sent to you for follow-up after undergoing therapy sessions? I mean to ask, are there any tools to measure the outcome of therapy? How do you keep the parents' morale high? What do you tell them? If the child is better, or is it the same, or is it worsened? How do you quantify that?
Well, I think quantification in objective terms is difficult, but as doctors, we always like to have that kind of a quantification. And that is why we try to come up with a scale in the pro forma that I just described in the presentation, where we kind of develop a scoring system which has two components to it. One is the clinical score and the home score, just like the way we have for intermittent exotropia, because child's functioning can be quite different depending on the environment. And depending on taking a particular task, like say, it's about facial communication. Does the child look at your face while talking? So does the child do that using vision only? Or does the child require help of other senses like hearing and touch? Or does the child require any additional environmental modifications like putting light on the face? So depending on which of these additional strategies are required, we can further stratify this function as low functioning, mid-level functioning, or high functioning. And as we follow up the child, we check on what additional help is required so that that function is achieved. So that is how we can try to stratify the functioning and assess the progress on follow-ups.
So what you mean to say is the assessment is purely qualitative, and you grade it into mild, moderate, severe, and not grade it between 1 to 10. I mean, there's no way to grade it. Okay, your child's just like for example, a Glasgow coma scale, where you quantify coma into 0 to 5 and 5 to 8 and 8 to 10. Is there any way of doing that with CVI so that you can say, okay, your child has scoring 4, now he's scoring 5, so he's doing better?
Yeah, as doctors, we all are fond of these numbers. And so we did introduce this scoring system in our pro forma, though from rehabilitation science point of view, it may not be very accurate, but that is how we understand things. So we have introduced that scoring system as well, which gives a score for, say, for the domain of communication, baseline score is 10, and now with a follow-up of 3 months, it is 15. So yeah, we have introduced that scoring system also.
Okay, the same question to you, Dr. Dutton. Do you follow any scoring?
No, because the straight answer, because every single child is unique, and therefore the scoring relates to their own profile. So what I've always done has been to elicit, go back on the old notes, identify precisely what the skills were, identify precisely what they could achieve, and ask the questions about each of the goals that were set. Because what we do is we set goals, and once the goal has been achieved, we move on. So a scoring system appertains to a medical approach, whereas an educational approach is a goal setting and attainment approach. So in essence, I moved on from a medical one into understanding the educational one in all its aspects with respect to those principal parameters of mobility, access to information, and social interaction. So how has the social interaction improved? How much has the ability improved? And how much has learning improved? So each one is actually not scored, but related to the goal setting and setting the next goal, moving forwards for that child, thinking within the mind of that child.
I think Dr. Namita wants to add something.
I completely agree with Dr. Dutton, but I also agree with Dr. Niranjan, and I realized that if we really have to work closely together, doctors love numbers, and don't seem to be able to accept a non-numerical graphical solution. I can share, I don't know, I'm pretty sure we're running out of time, but otherwise I could share with you. We create per goal, per activity, visual goals. And inside
No,
that,
Dr. Namita, I don't worry about the time. If you want to give an example, it will be very enlightening.
may I share screen?
Sure,
I
definitely.
actually,
Please go ahead.
Okay, I'll, hold on. I hope I opened the right thing.
I'm a very bad moderator when it comes to time.
Do you see my screen?
Yes, we do.
Okay, so this is an example documenting progress of a specific child. We look at a bigger activity, which is during an interactive session, mom and child. We are looking at specific visual goals. We are, of course, looking at more than those just vision goals. We are looking at many goals, but I've only pulled out the visual goals. We want to know whether we can increase the amount of time over an overall period of a 40-minute session. There's about 30 active minutes of interaction. We want visual goals of increasing, establishing and maintaining visual contact with parent face and the object over a period of time. The evaluation parameters that we're using is sustained attention at a stretch, sustained attention over, that is an additive number over the entire session, and whether we had to elicit, the parent had to elicit or didn't have to elicit. This is a very big area for me. If I see a child who doesn't need attention, visual attention elicit, that's a very strong indicator for us. So we actually grade that and say no visual attention, fleeting glance, less than 5 times, blah, blah. You pick what makes sense for that child. Please do not pick this up and use it across every child you come across. It's for that child, understanding their situation. And we grade it 0, 1, 2, 3. And then we actually document, depending, I mean, if this is a parent session, I'm not going to ask them to do this level of documentation, but we would have recommended the kind of environment, the kind of object, blue one shows you visual.
Dr. Namita, we can't hear you. Maybe because of the net problem. Can you switch off your video? Then we can hear you.
Sorry. Am I back? I'm
Yes,
going
you
to
are back.
stop my video then maybe. But essentially, that's how we do it. We kind of do the in-between. We can't do this with every child. As with the medical profession, we also deal with large numbers of children. But in cases where we know the child closely within a hospital setting, then this is sometimes a useful way to document and record change and also explain why something is particularly important for this child.
So I believe, it does answer. What you are arriving in, as what Dr. Dutton also said, is probably required. What is required is an individualized progress sheet for every child and not a standard sheet which every child has to conform to. And that makes perfect sense. I have been told that there are only 10 more minutes left. So I will just take up the most important questions which I feel. Dr. Dutton, do you feel that there is a particular age at which a child should start therapy, and is there an age beyond which therapy will not help as far as neural plasticity is concerned?
what we find is that the children with the most severe pathology present the most early, and they need intervention now. So the age in this context is very early intervention with regard to training of vision and to bring vision on. But there could be a presentation at the age of 6 or 7 with much higher levels and the first recognition ever of impaired dorsal stream function. And that, of course, is intervention at the point at which it's identified. So the bottom line is intervention.
Okay, so you have to intervene at whatever age they present, and see if it works. To Dr. Niranjan, in your experience, what makes you feel that the child is getting proper rehab as opposed to suboptimal rehab? When do you suggest your child to change the therapist?
This is a super googly, Siddharth. Well, I think parents need to have realistic expectations, and it is the job of the physician to set the ground in his first session of counseling as to what we are trying to address. And the objective of interventions is not to improve the acuity of the child, but the ability of the child. And we prioritize depending on what is the parent's main concern about child's vision. We set the goals and try to chase those goals. What we have seen is that the first 6 months are most crucial. If any improvement has to happen, it happens in first 6 months. And that is because that is the time when parents have maximum enthusiasm and they tend to follow your advice very well. So first 6 months are crucial. And beyond that, if we still do not see a change, we need to reassess ourselves. It's something like why the amblyopia therapy is not working, and try to address those reasons. So I think the parents can take a call depending on what they feel about the therapist. Is he having that comprehensive approach towards vision, or we are just trying to, play around some games in dark? Is that what is happening, or is it actually connected to day-to-day activities? So I think it's a difficult question to answer.
Sum it up, what you are saying is that if some goal has been decided and in a finite period of time it is not being achieved, then you have to assess the approach.
Exactly, yeah.
The same question to Dr. Namita Jacob. When do you ask your patient to change his ophthalmologist? In other words, in other words, what do you expect your ophthalmologist to tell you?
Well, I have to say I've been extremely lucky. I think India in general, the field of ophthalmology, we have some really, really, really brilliant ophthalmologists. It's been very easy, honestly, to have a partnership with them. This is something we look for, a partnership. I think for us, for me anyway, the biggest no-no is an ophthalmologist who doesn't partner. It becomes very hard for us to do our job. The more complex the child, the more important this partnership. 2, an ophthalmologist who does not listen or respect a parent's perspective. It's one thing to help a parent understand why a certain approach may be, for example, maybe inappropriate for your child. It's another to say very bluntly, your child is blind, nothing can help your child, when the child is in fact not blind. A child is unable sometimes to use the visual capacity or the visual potential that they have. So it's about their ability to see the child versus see the eye, the ability to partner, and the ability to respect the importance of a child's, of developing or supporting a child's vision and function, both.
Okay, so we have got all the questions in now, and I don't have any more pending questions here. So I would like to conclude the session now with hand it over to Dr. Mallikarjun to give the concluding remarks.
Dr. Shakti Das will do vote of thanks.
I'm sorry, Dr. Shakti Das for the vote of thanks.
Okay, thank you. Good evening. This is a great learning experience. Previously, all we are any patients of cerebral palsy coming to us, we have been examining as an orthopedic surgeon, physiotherapist, occupational therapist, speech and psychologist. Now a new field has been already explored now, vision therapy or anything related to ophthalmology. So recently Government of India has opened some early intervention centers in which they have added a post of optometrist. I think they can be trained in that line, that I at least learn from it, so that we can have an idea of multidisciplinary. As Indian Academy of Cerebral Palsy, our aim is to disseminate the knowledge, and the new area is today explored, which will be helpful to all our participants, those who are joining today. We have got physiotherapist, occupational therapist, all are in the participants. So again to convey my vote of thanks, I first I convey my sincere thanks to Dr. Lahane. In his busy schedule in COVID times, he has come and he inaugurated the seminar. From the beginning, our board of director, Dr. Sasikala ji there, I also thank her, and Dr. Usha Johari, who has arranged this seminar, and as well as she has delivered a lecture. So thank you, madam, for the today's webinar. Wholeheartedly, I thank you, and also the past residents, Dr. Firoz and Dr. Banaji, those who are present. Sir, thank you very much for present in this seminar. And Dr. Siddharth, I am thankful to you that you have today you have this moderated the session. You are from Bhubaneswar, I am from Orissa. Thank you very much. And also thanks Dr. Dutton, who has huge experience in this field, and who has informed all the participants about this field, so that this really now it is a multidisciplinary approach. Vision is an important aspect of the multidisciplinary team, and we have to now see how it will be included in our curriculum in this country. And also I thank Dr. Niranjan and Dr. Kruti for their lectures, as well as all the coordinations in this webinar, and helping us. Dr. Namita Jacob also sharing her experience. Thank you very much, madam. And also Dr. Mr. Mulinath, the parents who have joined and shared his experience. It will be also helpful to all the participants, and as well as all of us also, how this is an important field. And lastly, I thank this team again, the webinar team, our captain, Dr. Taral Nagra, helped by Dr. Asa Chitnis, Dr. Minakhi from Nagpur, Dr. Madhvi, and Dr. Sanket. Those who are in the behind the screen doing a great job. And without their help, it is just impossible to conduct this webinar. They have so much devoted so much of time. Thank you very much. Thank you all the team. And lastly, I again thank our board of directors, our president, Dr. Mallikarjun, those who are guiding time to time to which subjects will taken up. So again, with all the webinar team, all the experts, I am conveying my sincere thanks and for helping us to spread the knowledge in the field of vision in the cerebral palsy. Thank you very much. Thank you.
Dr. Usha Johari, ma'am, you want to have the last words for this webinar? She worked really hard to make this really happen. And if this was visually possible, it was because of one person. Ma'am, please, if you can say something.
Yeah, I mean, I'm extremely grateful to the Indian Academy of Cerebral Palsy for giving an opportunity, to enlighten all of us about the eye problems in cerebral palsy. And I think Dr. Dutton, Dr. Niranjan, Namita Jacob, Dr. Siddharth, all the team members have done done extremely well, and they've, enlightened us with a great knowledge on why every child with cerebral palsy, the eye checkup is a must. So I thank you once again for giving this opportunity, and we wish to have many more, such webinars in future. Thank you.
Dr. Mallikarjun, can you please announce about the next activities before we say goodbye to them?
Next webinar we may be having on listening session with from all over the country. We want to involve parents and children, persons with a cerebral palsy, interact with all the professionals who are working for them under the COVID time, how to manage these children, to solve their problems and counsel the parents and hear them and listen to their problems. We want to have a webinar at the end of this month. And the next webinar, if our Honorable Board of Directors, sir, our mentor, Professor Johari, sir, if he permits, we'd like to have his webinar in the month of July. We welcome you, sir. Thank you very much, and I really thank Dr. Usha Johari, madam, for taking a lot of pains to architect this webinar. We had one of the best webinar today on Visual 2020 in cerebral palsy. Thank you very much, Dr. Gordon Dutton, and we would like to share your poem on CVI with all our members of Indian Academy of Cerebral Palsy and attendees. Actually, we wanted to share the screen of your poem, and it is a wonderful talk. All the attendees, we received a feedback. It's a enriching and wonderful, excellent talk on CVI. And Dr. Niranjan, Dr. Namita Jacob, and Dr. Kruti Shah, thank you very much for your talks. And we thank all of you for attending this webinar. Thank you, Usha madam. Thank you, sir, has joined us very late.